Welcome everybody to July's qiCommunity. So today we are lucky enough to have Dr. Chris Bollen discuss kidney health. Chris is a busy GP at Oakden Medical Centre who has an interest in improving both clinical and business outcome in general practice. He is also director of the BMP Healthcare Consulting, a management consulting company helping general practices to deliver safe and effective care. Chris has membership to the Primary Care Education Advisory Group to Kidney Health Australia, and it is within this role he will share his expertise. So welcome, Chris, and thank you so much for joining us today.
Thank you very much, Sarah. Thank you very much, listeners all around Australia. It's fantastic to be here. I'd like to also dedicate today's session to a fantastic renal physician, Professor Tim Matthew, who unfortunately died on the weekend. Tim was the medical director, or ex-medical director of Kidney Health Australia, and was a real visionary in improving the health of Australians with chronic kidney disease. And he really helped set up a lot of the great work that Kidney Health Australia does to support general practice in its quest to improve kidney disease. So I think it's just a moment to reflect that he lost a great man in Australia. And he was the man that rang me many years ago to say, would I become interested in kidney health? So thank you, Tim. So let's get underway, because today's topic is about how we can improve the health of Australians with kidney disease in general practice, and looking at how we can use some improvement principles to do that. So we've got some learning objectives today, and they are listed on your slide, which will be there. And really we'll just remind you about some of the improvement principles, look at our definitions of chronic kidney disease, and help you reflect on how you can build and test a register. But really importantly, I want you all to sort of really take away from today why the imperative of why we should be treating chronic kidney disease, and because of its importance in delaying progression of long-term kidney disease and preventing a cardiovascular event. And we'll talk about this in the context of developing a system for your practice. So let's first look at the definition. The definition of chronic kidney disease, there are two parts to the definition. And the first one is where a person on their blood test, which is routinely done in many practices as an MBA20 or a electrolytes and kidney function, comes back with an estimated, or eGFR, estimated glomerular filtration rate of less than 60 mils per minute. It's important to look at this definition in the fact that it's for 3 months or more, and the person may or may not have any evidence of kidney damage. Now, that's the thing that we're actually most aware of when it comes, because these blood tests come back into our practices, and we're seeing them. Sometimes they're highlighted in red, sometimes they're not, when the eGFR is below 60 mils per minute. The other part, and this is actually more than half of the people who have chronic kidney disease in Australia, will have some evidence of kidney damage for more than 3 months. And that's where they have a protein in their urine. And albumin is one of many types of protein, and it's probably the most important in this area. And so if someone has a micro or macro albumin, then that's a sign of kidney damage. Their filters, which actually filter the blood, are actually damaged, and they're letting protein into the urine, and that's what we're detecting. So that's a sign of kidney damage. So it's really important to look at those two parts of the definition, either one or the other, and sometimes both of them exist together, which is actually even worse off for many patients. So then we'll look at why do we need to worry about this? Because it seems as though many people might have this reduced glomerular filtration rate, but not much is being done about it. And that's one of the really important things why we're having this webinar today, is to actually raise awareness for one of the biggest public health problems in Australia. It's chronic kidney disease, and the progression to renal failure and renal death is number 9 on the list of cause of death in Australia, and it's higher in that list than prostate cancer and breast cancer for cause of death on an annual basis. So it's huge. And so what we want to look at is that how can we actually prevent it? Because if 1 in 10 Australians has chronic kidney disease, it's going to be very prevalent in our general practices. However, only 1 in 10 of those people are actually aware they have the condition. And unfortunately, many health professionals across the board are often unaware of the importance of chronic kidney disease. And so not a lot is getting done when it comes to identifying and managing chronic kidney disease. It's a big impact because really, before you get any symptoms, you can lose a lot of the function and feel well. And so that's often a lot of changes occur before it's too late. But most importantly, it is an independent risk factor for cardiovascular disease. And by what I mean by that is that we're all very well aware of our cardiovascular risk calculators, the usual raised blood pressure and lipids and smoking as being risk factors for cardiovascular disease. But if you've got chronic kidney disease, you are between 2 and 5 times as likely to have a stroke or a heart attack compared to people that don't. So it's a huge risk and it's treatable. So we need to know a little bit more about, well, how can we do something about this in our practices? And so really it gets back to some of the models of improvement. We go, well, what's the problem we need to improve? Clearly, we've talked a bit about it. It's about raising your awareness of chronic kidney disease and then doing something about it. So we need data, don't we? If you think about improvement, you can't, unless you actually start measuring something, it's hard to know whether you've made an improvement. So we really need to start thinking about, can we form a register of people who have chronic kidney disease in our practice and a register of people who might be at risk of chronic kidney disease. They're the 2 fundamentals that we need to start with, because if we don't know who the people are who have chronic kidney disease or who are at risk, then it's very difficult to do the next steps, and that's implement a prevention and management program, just as like we would with diabetes and other chronic health conditions. We also need to know, well, who's actually getting kidney health checks? And we'll talk a bit about what a kidney health check is a bit later. But we need to know, are they actually being done? Because they're a hugely important part of monitoring progression of disease, but also monitoring people at risk whether they develop the condition. So it's really a really good example of great primary care, which is patient-centered, coordinated, comprehensive, and driven by quality and safety, where we know measurement is important to improve the quality of what we do. So how do we look at these registers? So many of you are using some sort of data extraction tool, and Penn and its suite of products is pretty popular, but also there's Canning, Polar, Granite, and no doubt there are more that are coming all the time. But I'd like you to think about this, because if we have a benchmark of what we should be aiming for in our practice, so 10% of our practice is likely to have a diagnosis of chronic kidney disease, but importantly, in our 75 plus group, 30% are likely to have a diagnosis where their EGFR is less than 60 mils a minute. And it's really important to actually not say, oh, it's just because they're old, that's why they've got a reduced EGFR. That's not the issue. Because even in 75-year-old to 105-year-old, it's important to recognize it so that you can actually not prescribe renotoxic drugs, or if they're on medications cleared by the kidney, they will actually have other side effects as a result of that. And if we don't recognize that, it's hard to actually do something different. So building our register, let's have a look at some reasons why we need a register. And the next slide will show us a bit about practice populations, where some research I've been doing with a lot of older people in practices. So you'll see there's 8 practices that I've been working with. Their total number of patients that are 75 or more and expressed as a percentage. the really important thing is then looking at their coded diagnosis of chronic kidney disease. So this is the group that there should be 30% of this group should have a diagnosis of chronic kidney disease. You can see the numbers there are relatively low. So that's an important improvement step, to actually benchmark yourself. Where should we be? Okay, if we are really going to be doing a great job with chronic kidney disease across our whole population, we need to lift those numbers. So what opportunities do we have to do this? If we look at our other populations in practices, so let's say diabetes. So here, these 8 practices again, they have actually really good coding for diabetes. You'll see that in this group, 75 plus, 18% of that population would normally have diabetes, but only much lower percentages have been recorded in these practices. So it's a really good example of going, funding actually drives models of care. We've been really well funded in general practice to start looking at diabetes, have lots of diabetes programs to think about improving our SIPs and PIPs and cycles of care. Other chronic conditions also warrant lots of attention. As you can see, chronic kidney disease is by far and away a big area in the older population. It's big across everyone, but clearly we need to focus on it in our practices. The next part we look at is, what's the gap? Now, when we talk about gaps in care, unless you actually know your population, then you don't actually know there's a gap. So this slide just shows in these practices that had big populations of people over 75, that they had missing diagnoses. So, anywhere up to 300 people missing a diagnosis. So that means the practice can't implement good prevention and ongoing management for a lot of their patients. So that's what we've got to change. So if we go to the next slide, we'll look at building a register. And this is using the CAT module. Now, many of you are maybe using other extraction tools, but this is a really good one where people haven't been coding chronic kidney disease. And the CAT module has a particular part where you can look for the chronic kidney disease with no diagnosis report. And this shows us the patients in our practice that basically have had an EGFR, and it will pick up that group, which is less than 60 mils a minute. It will also pick up those people that have also got a positive albumin, raised albumin level in their urine. So the report displays some really key pieces of information to help you make decisions on management. But what it doesn't do, it doesn't go and then code it for you. What you have to go and do is actually go into each of those patients' notes and put the diagnosis of chronic kidney disease. And even better, if you can actually code it with the stage, because that's an important part of understanding what is going to happen to that patient. So chronic kidney disease stage 3 is really the first part. We need to look at it, and that's where we have an EGFR of 30 to 59 mils per minute, and stage 4 is 15 to 29. Now, the risk of cardiovascular disease is twice as high in stage 3, but it goes up to 3 to 4 times in stage 4. So knowing where your stage is important. So then we look at what the register could look like. Now, this is something, again, from Penn, which gives us a report on how clinically we are progressing the management of chronic kidney disease across the practice. And it's a really nice report that really talks about how we're going with blood pressure, and it's both, has it been taken, what the target is. And just to refresh your memories, the target for chronic kidney disease blood pressure is 140/90 or better. But if the patient has chronic kidney disease with a urinary albumin level that is raised, then their blood pressure goal is much lower, 130/80. So this particular report tells us about BMIs, LDLs, other lipid issues, and whether a ACE inhibitor has been prescribed. They're one of the most important steps in actually halting the progression of chronic kidney disease. So very useful to look at your register and its report. The next thing we need to understand is, well, how do we identify chronic kidney disease risk? And this is going to alarm many of you listening to this webinar, because 30% of the Australian population is at risk of chronic kidney disease. And on the slide, you'll see the risk factors. So our friend diabetes is there, hypertension, anyone that's had a coronary artery event or a stroke, family history of kidney failure and kidney disease, BMI over 30. Yes, obesity by itself is a risk factor for developing chronic kidney disease. And as we all know, obesity is rising in our practice populations very rapidly. So it means chronic kidney disease will also be rising with it. Anyone that smokes is at risk. And then in the ATSI age group, anyone that's over 30 is at risk. And that's slightly out of sync. The history, anyone who had a history of acute kidney disease in their previous time, that's also a risk factor for developing chronic kidney disease later in life. And all of that can be shown on the reports, which we'll just put on the screen next, because Penn has put this at risk of chronic kidney disease register there. And this is, again, hugely helpful in monitoring your population. You can see who's at risk, and you can then look at whoever's at risk and who's actually been having their potential checks. So the yellow is where a risk factor is not recorded, and red is where there is a risk factor. And you can go in and then create that register. Every single one of those people needs an annual kidney health assessment in order to see whether they develop chronic kidney disease, and then put them on their ongoing monitoring for their blood pressure, their urine albumin, and their EGFR. So very useful tools that you have at your fingertips in your practices. It clearly requires you to build your team to know why they're looking at it. So you really encourage practice education, whole of practice education, set some goals, get everyone across the practice knowing the importance of chronic kidney disease, and assigning roles and responsibilities for who's going to be involved. So that's the registers, but I want to also make you aware of some other aspects of making chronic kidney disease work easier to do. So many of you would have heard of this little maxim: make the right thing easy to do, and it will be done. If we just tell you, go out and search for people with chronic kidney disease, some of you will actually, go and do it. But what we're going to do is try and think about ways of incorporating kidney health checks into our everyday work and our practices. And many of you out there listening will actually already be doing care plans for chronic kidney disease, diabetes, heart disease, osteoarthritis, and many other chronic conditions. We know that this is a great opportunity to embed other areas. So what I'm going to suggest is that if we put a kidney health check into a care plan for diabetes, which it should be anyway, because you know that checking urinary albumin levels are part of the cycle of care for diabetes. But if we put it into a heart disease, stroke care plans, it's more likely that you'll get them done. So if you put a needs annual kidney health check in those care plans, it's a good way of getting it embedded, so you don't have to think very hard. It's just there, it's in your template, and it's something to be done on an annual basis. The other big group is those of you that have care planning for people with osteoarthritis. A really interesting statistic is that people over 65 with osteoarthritis, 50% of that group is going to have hypertension as well. So osteoarthritis probably affects 3 out of 4 people in the over 65 age group, and 50% of them are going to have hypertension. So you're going to have a lot of your over 65 cohort on care plans for osteoarthritis, have hypertension, add a kidney health check into that care plan. And then it will just get done as a matter of, this is what we do around here, part of your culture and your practice, making great care happen. Also putting it into your 75 plus health assessment as a recommendation, annual kidney health check, is another great way of actually using your existing system to maximize what you can do. It's a really high value because you're targeting the group that you're already seeing, and many of them aren't getting kidney health checks done. So just a little tip on how to make good stuff happen in your practice. So what is this kidney health check? So let's go into some detail on the next slide, and we'll just refresh our memories on what it is. It's pretty simple. So an annual blood test where we're having an EGFR done, and that requires a creatinine level to be taken as part of, so on the blood test it would simply be MBA20. Some companies, if you just order a liver function test, it orders the whole 20 things, including creatinine and EGFR. Or if you ask simply for renal function, which is very focused just on your kidney health check, plus an annual albumin level of the urine. Now, this is really important. You do not need the 24-hour urine save, like in the old days. You can just do a spot urine sample first thing in the morning and a form asking for a urine albumin creatinine ratio, and then a blood pressure level. So that, and dipstick testing, I just want to remind you all that it is not sensitive enough for chronic kidney disease. So it won't cut the mustard when it comes to making a diagnosis. You need to send the urine sample to a pathology company to make this happen. And so really, that's the kidney health check. So if you embed that into your care plans and health assessments, many people are going to have these things done already. So if you focus it as a kidney health check in your care plan, you can then start socializing it, talking about it, talk about its importance across your practice. The next thing is just a brief rundown on the chronic kidney disease, the staging. This lovely graph in front of you comes straight out of the Chronic Kidney Disease Management and General Practice Handbook, which is available online, and it helps you understand the red, yellow, green aspects. So red being, that's the group we most need to be doing things about. They need to be seen every 1 to 3 months to have everything checked as far as what changes are happening with their blood pressure, their medications, their weight, their EGFR, how much is it changing. We also need to look at the yellow group. They need roughly 3 to 6 monthly, and the orange group, the orange group is 3 to 6 monthly, and the yellow is 6 monthly. So, and that all depends on their GFR. So the next slide will show you an easy way of doing this. And that's an app called the CKD Go app. And this has been produced by Kidney Health Australia to make chronic kidney disease easy. And you'll see that little, if you download the app, you just put in the person's EGFR and a number of other basic pieces of information, and it will actually come up with the management plan for you on your phone. So the smartphone helps you in general practice to actually make good stuff happen. And then you can enter the requirements into the care plan as you go, or into your clinical notes. So that's a really useful tool to download. I use this regularly in my practice to help me work out what needs to be done for each person with chronic kidney disease. The other thing that is just worthwhile reminding about is these treatment targets. And so they're up there. We've talked a bit about the blood pressure. Cholesterol, really important to get people onto statins. Now, unfortunately, one of the problems with PBS is that if you just have chronic kidney disease and a cholesterol of 6, and that's the only risk factor, you won't get PBS subsidized statins. You need to have diabetes and other risk factors to be able to do that. But it is a little bit of a glitch, but for the majority of people, you'll still be able to access it. You'll find other reasons that they'll comply with the guidelines. However, if they don't, then it would be a private prescription. Looking at the self-management, because one of the parts of it, of the improving care, is actually getting our patients to do better stuff for themselves. And the Kidney Health Australia has put out this self-management handbook called My Kidneys, My Health. And this actually is fantastic in that it helps people either via an online handbook or an app for their phone to look at things that they can do to prevent kidney disease progressing for themselves. And it's, again, very helpful for people to know that they can do things that can help change the course of their illness. And really, a lot of it comes back to diet. So we go to the next slide. It just talks about some of the lifestyle effects that can reduce blood pressure. And the My Kidneys, My Health information helps people look about what are some things they can do themselves to actually change outcomes. So we know diet, reducing alcohol, increasing physical activity, and reducing your salt and weight are all key factors in improving outcomes here. So that's all on the My Kidneys, My Health book. Making care safe. The other thing to remember, I know there's not much time to go, but if you look at home medication reviews for people with chronic kidney disease, really important safety aspect. But this is back from this research I was involved with, that HMRs were being done, but they weren't being done focused on chronic kidney disease. So older people are often on 8 or more medications, and they're the ones that need HMR. So I'd like you to think about another system issue in your practices. How can we get more HMRs done for people with chronic kidney disease? And you'll find that your pharmacist colleagues, if you let them know the person has a chronic kidney disease, they will focus their advice on which medications are suitable for that person. So finally, we'll talk about what we need to do about improving your community's care. One of the things we're really good at doing in general practice in Australia is actually seeing people. You know, they get the care. But there's a big group of people who are not getting the care they really need. In every practice, it's probably about 25%. There are big care gaps. Chronic disease and chronic kidney disease is where the big care gaps exist. So I hope that looking at some of the guidelines that will help you understand how you can use data to improve care in your practice, be proactive in delivering care to those who most need it. You know, the 30% who are at risk of chronic kidney disease need that care. Let's think more about proactive approaches and the focus of being accountable for the care we provide. Some of you are involved in healthcare homes. The patient-centered medical home philosophy is where we need to think about accountability for care. Chronic kidney disease is a great example. So I'd like to just summarise today's session and really think about what we've aimed to bring to you. It's a really common condition, 1 in 10 Australians, 30% over 75. It's treatable, and we need to actually do something about picking it up early because cardiovascular disease is its big cause of death. And you can do something in your practices if you identify who's at high risk, an annual kidney health assessment, because that's what's going to actually help your patients. Simple things to do. Look at your blood pressure, 130 on 80 if they have albumin in their urine, and 140 over 90 if they don't. And have a look at the apps on your phone or the CKD Management in General Practice Handbook. You need to refer only a minority of patients. So when you're seeing deteriorating GFR rates, that's when you need to refer. Get on the phone to your nephrologist, have a chat to them, because a lot of the stuff you can actually do in your practice, and there's long waiting lists to see them in their hospital rooms. But get on the phone, have a chat, learn what they'd like done, and you can manage it yourself for the majority of patients. And actually, don't forget to ask about their medications, because it's one of the biggest areas in Australia where medications which are toxic to kidneys are causing deteriorations. Happy to take some questions now. We're bang on 1 o'clock. So Sarah, any questions come along?
Not that I can see. If anybody does have any questions, please just hit the little raise your hand icon and I can unmute you. Otherwise, you're welcome to email myself and I can always send through some questions later.
Yep, that'd be great. I think one of the things that we put on the resources for everyone is some examples of what we can be doing in our practice as far as what we can measure to actually think about improvements in care for people with chronic kidney disease. So I've got about sort of 12 or 13 there, and there are some other changes we can make in our practices. So, you know, one of the things, having a monthly display on our wall about kidney health, you know, trying to line it up with March, which is Kidney Health Week. We put make our patients aware, but also make all of our team aware, because it's such a huge problem. Every person, from the receptionist through to the practice manager, the nurse and the GP, they all need to be aware to make a change happen in our practices. So if everyone's talking about it, let's put our data on our walls so that we can actually say, well, how well are we doing with chronic kidney disease? Put it in your tea room. Get people to talk about it, because it helps build the team. If everyone actually knows this is the goal of our practice, to reduce the effect of chronic kidney disease in our community, then we should all be talking about it. And tea rooms are great ways of engaging your staff. So that's 1 o'clock. So Sarah,
yes.
no questions seem to have come up at this stage?
No questions at this stage. Yeah, and very good timing, Chris. That's fantastic. Dead on 1 o'clock, so that's fantastic. So thank you so much, Chris, for coming and speaking for everyone today. The topic was so relevant, as well as just giving some excellent practical advice to people as well. So for next month's webinar, we haven't quite confirmed who will be speaking, but we will be sending out an email via the newsletter as per normal, so please keep an eye out for that. And in the spirit of improvement, can I please ask that you fill out the evaluation form that pops up at the end of this. So thank you so much, Chris, and thank you for everyone's attendance today, and I hope to see you soon.
Fantastic. Thanks everyone for being involved.